Hey, everybody, Dr. Z, welcome to the show. Today, we're going to talk about abortion. That's right. Nothing too controversial, right, Alex?
No, not at all.
So, this is Dr. Alexandra West. Alex, if you're nasty, she is an assistant professor of obstetrics and gynecology at the University of Connecticut and an expert in women's health and reproductive health. So here's the story, right, Alex? I had done a piece using Doc Vader as a mask to
Yes.
talk about the Roe v. Wade overturnment that might be
Mhm.
happening. And I put it out there and, it was a little tongue in cheek, a little comedic because I'm scared to talk about those things because I'm a dude.
Yeah.
And you wrote this really amazing comment because you're one of my supporters in our supporter tribe and you subscribe and we have these live shows. And you wrote this great comment that was like, listen, I got a great sense of humor, I think, but like, this issue is something you really ought to talk about properly because there's medical stuff at stake here. There's bioethics. There's all kinds of stuff that the media never talks about. So you should talk about that. And I'm like, well, cool. Why don't you come on the show and we'll talk about it? And you were like, all right. And so here we
Yeah.
are. So welcome.
Thank you.
So you were a dancer before you went to
Yeah.
med school, right?
Yeah, I was. So I grew up all over the country and I was a classical ballet dancer. I did get paid to dance ballet, not on the pole. And then,
I was going to say, when I said dancer, I was like, I hope she says ballet because
yeah,
otherwise it's going to get real.
yeah. Well, I mean, I probably would have made more money on the pole. So unfortunately, I chose the higher art form. But I had kind of suffered one injury, had surgery, and then I was like, you know what? I'm just going to go to college. I went to Tisch at NYU and majored in dance and was a double like pre-med person. So I'm like a masochist. And then danced in the city and taught yoga for a little while, and then and did some research and was a medical assistant, and then had more injury. And I was like, screw it, I'm going to med school. I need insurance. So went to med school, and then I chose obstetrics and gynecology. So just continuing with just really choosing easy things.
Wow. You did all the things. So basically you're like my favorite person. You did the arts with ballet.
Mhm.
You did yoga instructing, which is mindfulness and meditation combined. And then you're an OB-GYN doc, which is a traumatic trigger for me because my first clinical rotation was OB-GYN at San Francisco General, and I'm still
Mhm.
recovering from it. So
Yeah.
this is kind of you're going to bring the circle full and teach me about stuff that I think many medical people actually don't understand. And
Yeah.
certainly a lot of lay people don't understand because abortion, pregnancy termination has been such a politicized, it's got moral elements, it's got religious elements, it's got belief, it's got science. I want to focus a lot on the scientific and ethical elements around abortion. And I think you're the perfect person to discuss it. So let's just dive in.
Yeah.
Why don't we start with, where do you want to start with this? Because you talk about this with patients. You're an expert in this. When you saw the Supreme Court leaked document, I mean, what sort of went through your mind? Because you provide, these services are important to women and medically necessary in many cases that people don't understand. So what was going through your mind?
Right. So, I mean, we've seen a little bit of this already in Texas with the SB 8 legislation. We're kind of seeing how this is going to play out a little bit. I'm really lucky to practice in a state where I can really practice the full spectrum of obstetrics and gynecology. So I am a general OBGYN. We do have some excellent colleagues who have an additional 2 to 3 years of training in complex family planning, which does focus on either complex birth control issues in people who have medical problems, the ethical components that surround abortion care, and also abortion care, especially the more difficult cases that go with that. But most OBGYNs, or actually all OBGYNs, are trained to provide abortion care, especially in the first and early second trimester. So I'm very lucky that I can have that be part of my practice, and I can support my patients through deciding about birth control, through an unplanned pregnancy or some kind of pregnancy loss, and then I can deliver their baby. And it's like really awesome that I can be there for my patients for their entire reproductive journey and not just one specific area, which is why I love my job and my specialty is the best. Um, but I think like the important thing is to really understand that abortion care is part of comprehensive reproductive care. And I think there's a lot of gray area. So calling something a pregnancy termination in a situation where maybe the pregnancy is not going to continue, but there's a heart rate, or deciding to choose pregnancy termination in the setting where there's a lethal fetal anomaly, or the mother has a medical condition or mental health condition that's not consistent with pregnancy. It's not going to make pregnancy safe for her. And then even managing miscarriage, where these laws come in and they're made by people who are not obstetrician gynecologists and have no understanding of how this stuff works. It makes doing my job and providing the standard of care to my patients as dictated by ACOG very challenging. And I think that what's going to happen to these laws is you're going to have a lot of OBGYNs like put in really difficult situations. You're going to have delay of care. And you're going to have a lot of physician burnout and moral injury.
Yeah. And I think what you kind of put your finger on is that there are people who know nothing about this stuff who are making legislation about it. And that's what's always bothered me. Like, you can feel many different ways about pregnancy termination from a moral standpoint, from a religious standpoint, whatever. But the idea that there are legislators who don't touch patients who are making these laws, and then folks like yourself who are actually with the patients. And there's a lot of nuance that you've already brought up in terms of how these things are done. So for example, I think 45% of pregnancies are unplanned. Yeah. So you start with that number, which is really high. And really you talked about the 16-year-old who, may get pregnant, or even the 12-year-old, right? And so there's that component of it. But some of the things you pointed out were, women who have an unplanned pregnancy who are really not either safe or capable of carrying that pregnancy to term, either because the pregnancy itself is non-viable, or because they have medical conditions or other issues that make it very dangerous to possibly impossible to have a child. And so in the absence of the option to have a pregnancy termination, what would happen to these women?
So, I mean, it really depends on the situation, and you can go through, different, like various clinical scenarios that kind of demonstrate the gradient of this gray area. So I think that if you start with, I feel like it's almost best to start with like, who gets pregnant and how do we date a pregnancy and what happens?
Yeah.
So firstly, like you said, 45% of pregnancies are unplanned. So why is that? So one is that access to birth control, depending on where you are, can be a challenge, depending on your health insurance, especially after there's a Supreme Court case where kind of overturned the Affordable Care Act's mandate that health insurance cover birth control. So some people can't afford or access birth control. Some people have medical problems that make some of our more effective forms of birth control contraindicated. So a really good example of this is birth control pills. So we have two kinds of birth control pills. So one that has estrogen and progesterone, and then one that has progesterone only. And the benefit of the estrogen is it makes it a little bit more user-friendly. If you forget a pill or you're a few hours late with that birth control pill, you're out with your friends, maybe you get a little drunk, you don't remember it until the morning, you're going to be okay if you take your next pill as soon as you remember. The progestin-only pills, you really got to take it at the same time every day. But somebody who might have a history of blood clot, somebody who has hypertension, you can't give those people estrogen because there's an increased risk of blood clots, heart attack, and stroke. So that's a really good example of, even if you're using one of these new apps where you can discourse with a physician on the phone and get a birth control pill prescription, the more effective version might not be accessible to you.
And remembering that there's a huge equity issue here. So we're talking about using apps and things like that, but like somebody with, a socioeconomic status that is not consistent with having a high-end smartphone with apps and things like that is already out of the gate at a disadvantage for this sort of birth control access, right?
Yeah, they are. Also, pills can be very expensive, and these pills have side effects too. So some people don't tolerate the side effects of birth control pills. And then we have our highly effective method. So that's your LARC, so long acting reversible contraception. So that would be like your 2 types of IUD or your Nexplanon, which is the implant that goes under your skin. I kind of tell patients it's like a piercing you can't see. It's fantastic. It's 99% effective. All of these are 99% effective. But it's very invasive to have an IUD placed. Some people don't tolerate the bleeding pattern. Some people have pain. Some people don't want something in their body because it creeps them out. And that's totally understandable. You also need to be able to go to a doctor's office to access this. So that's another example where we have highly effective methods of birth control, which are also at risk of being legislated right now, that not everybody can access or doesn't work for everyone.
Yeah, no. And so, in the absence of that, or where you're putting up legislative barriers to that, it becomes really difficult then to say, well, then what other options would women have if you can't have a pregnancy termination? The idea, again, is to reduce the number of pregnancy terminations through good family planning. And you've already pointed out how that can be difficult. Are there other issues around that in terms of, and again, it does strike me as it's not fully equitable either, because there are a lot of women with a lot of financial means, et cetera, who can access these things, but others can't. And then to tell them now, well, okay, now you're compelled to have an unwanted pregnancy and bring it to term, et cetera. It seems it actually speak to this for a second. The medical ethics around this. There's the idea of autonomy, justice, beneficence, non-maleficence. Can you talk us through some of that when it comes to these issues?
Yeah. So there's autonomy, right? So that's the idea of a person has the right to decide what to do with their body. So, and the way that I practice is I tell patients, like, listen, my job is not to tell you what to do. My job is to figure out what's going on, listen to what's important to you, and help you make a decision that's consistent with your wants, needs, desires, and your life. And so that's the best way, I think, to talk about autonomy. And then, so that already gets into, birth control, that's how I talk to patients, right? I can tell them what's most effective, but if that's not what they want, it's not what they want. That's okay. But now we're getting into a situation where maybe what somebody doesn't want is what they need because they have some other medical problem or there's something going on. It's also, again, getting into like the idea of bodily autonomy. And I think that gets down into a rabbit hole that it could be a whole separate conversation, right? Beneficence is helping a patient do what, like, good by them. So helping a patient to achieve their health goals in the best possible way, right? Non-maleficence, not hurting a patient. And I think that as we get into this conversation, that's what makes this whole legislative nightmare very challenging as an OBGYN, because if you're taking an option away from me to offer a patient, I'm essentially, I can hurt them, right? So I'm saying, well, you have, your cervix is 4 centimeters dilated and you're 14 weeks pregnant, but the baby still has a heartbeat. So you're not septic right now. So I guess we just have to wait until you're septic or you pass the pregnancy. You're taking away the safest option I have to offer that patient.
Right. So in essence, your hands are tied and you can actually harm a patient because your options are taken off the table.
Yeah.
And so that's a non-maleficence and not hurting somebody, beneficence, trying to help them, autonomy, giving them control. Now, people might push back here from an ethicist standpoint and say, well, if life begins at conception, then what about the ethics of the fetus? And how do you think about that?
So, I think in that particular clinical scenario, so we call that a missed abortion, which is like a missed miscarriage. So also when you're in obstetric and gynecology lingo, so if I say missed abortion, what I mean by that is you've had a miscarriage, the pregnancy is not viable, but it's still inside the uterus. So I can even see with some of these laws of just, if you look at somebody's notes and you don't really know what you're doing, you might misconstrue a miscarriage for, an actual elective termination. So there's that. And then there's also something called cervical insufficiency. And so cervical insufficiency is where the cervix dilates and it's painless. There's no contractions, there's no preterm labor. And then ultimately, people will either get infected, break their water, or go into preterm labor and deliver. And this can be devastating for women. So imagine a woman who has tried for years and years to become pregnant. She used IVF. She spent $30,000 to get this pregnancy that is highly desired. And then she comes in to labor and delivery at 15 weeks. And she's complaining of, I just feel weird. I feel pressure in my vagina. And I'm having this like spotting and I don't really know what's going on. So, you put a speculum in the vagina or you do an ultrasound and you see the cervix is 4 centimeters dilated, 15 weeks. There's membranes ballooning into the vagina. So in some circumstances, we can do something called a rescue cerclage, which is where we actually put a stitch in the cervix to try to keep the pregnancy inside until you get to viability, which in most states and circumstances, we say is about 23 to 24 weeks. But in some circumstances, that's not a feasible option. And so now you have this woman who is devastated, and you have to tell her that her highly desired pregnancy is that she's already carried for 15 weeks. So 15 weeks is what, almost 5 months, 4 months, no, 3 months. Yeah, I know. I don't think of pregnancy in months.
Math is hard. That's why we're doctors.
Yeah. But a substantial amount of time. She's probably already told her friends and her family. And so in my practice, what I can offer her is 3 things. So one is I can say expectant management, which is where we watch and we wait and we see what happens. The benefit of that is some people just don't feel like they can make that call or make that decision, and that's totally fine. The risk is infection, sepsis, hemorrhage. And then whether or not you send someone home or not, right? So typically we'd keep somebody in-house, but that's expensive. And depending on their health insurance status, that might be something that's challenging for them. They might have children at home. They might have, a job that they need to get back to. So that's one option. Option number 2 would be to give them medication that allows their body to pass the pregnancy. And it feels very natural. It feels like they deliver the pregnancy. And then option number 3 would be to take them to the OR and do a D&C, which is where we remove the pregnancy for them. And this is not a viable pregnancy. This is not a pregnancy that's going to have a good outcome or even an alive baby. But technically, this is a pregnancy termination. There's a fetus with a heart rate. And so what makes some of these bills challenging is if they're saying, well, if the life of the mother is at risk, then you can do a termination. Her life isn't at risk right now. It will be if she gets septic. And that's going to make a D&C procedure way more risky for her. And it's going to do things like increase her risk of hemorrhage, increase her risk of needing a blood transfusion, ICU admission, possibly a hysterectomy. And it increases the risk that we create scar tissue in her uterus. It's going to make another pregnancy more challenging or impossible. So that's just one scenario, right, of many.
And so this is a scenario where by saying, well, we cannot do the termination until the mother's life is at risk, what you're actually doing is putting increased risk to the mother's life in advance, because you want to do that procedure when she's stable, before she's septic, before things are hitting the fan. And you're unable to do that if they've legislated it that way, correct?
Right.
So now one thing, even just this idea of, viability and all of that, and it may vary state to state. You were saying around 23 weeks, but even dating a pregnancy, which we were alluded to earlier. And then I want to come back to one thing I want to make sure I follow up on is the question about fetus versus mother from a bioethics standpoint. But going back to how do you even date a pregnancy? This can be challenging, right? Yeah. So if there's legal limits on how to do abortions, how do you even know how, so walk me through that. And is it also the case that in many cases, in a lot of cases, women can actually miss the fact that they're pregnant for weeks and weeks and weeks, and there are cases where that can happen?
Yeah. So how do you get pregnant? So I think the best way to start with is, how do you get pregnant?
Is
So
this a
that's
birds and a bees thing? Because I never got this talk from my parents. They were too scared. I had to look it
yeah.
up online, and there was no internet in those days.
So how does one get pregnant? I get to have this conversation all the time, and it's a really fun conversation. So most people, and that's very loose, right? A menstrual cycle can vary in time, but we presume a 28-day cycle, which is 4 weeks. On average, you're going to ovulate some in the middle of that. So like day 14. You have sex within that fertile window. So let's say you're trying to get pregnant. You have sex within that like fertile window. Sperm can survive a long time. So you've got about like 4 to 5 days before you ovulate, and then like a day or two after you ovulate, right? So you've got about a week. So even somebody who's using like the rhythm method or like timed intercourse, you can still kind of miss that and end up with a pregnancy. So you're going to get pregnant halfway through that period. The way we date a pregnancy. So if you hear somebody say, oh, I'm 6 weeks pregnant, we date the period, or we date the pregnancy from the first day of the last menstrual period. Mm-hmm. So the first, when you are 2 weeks pregnant, you're actually not pregnant. You just ovulated, and the sperm just got into the egg, and then it's headed to the uterus. So when you're 4 weeks pregnant, so that's 2 weeks after your ovulation, and kind of when someone's about to be like, oh, I'm late. That is when you're going to have a positive pregnancy test, assuming a normal pregnancy.
So sorry, how many weeks was that again?
That's 4 weeks pregnant.
4 weeks.
Okay. So some of these states do have gestational age bands that hit around, or they call them heartbeat bands, that hit at around 6 weeks. So if you are paying attention to your cycle and you're somebody who's like timing your periods and checking your temperature and checking ovulation, and you're going to like do your pregnancy test, like that very first day, it's probably going to be positive. You're going to catch that positive pregnancy test when you're about 4 weeks pregnant. So if you're in a state like Texas with a heart, we're looking at heartbeat from that date until when you're going to see a heartbeat on an ultrasound. And when we say heartbeat, it's kind of a misnomer. The heart's not really formed at 6 weeks. It's more like there's cells that beat in concert. So it's more like electronic cardiac, cardiac activity that you're seeing. That's gonna 6 weeks is when you see that. So if you're actively tracking your cycles and you take a pregnancy test and you figure out you're pregnant at 4 weeks, you have 2 weeks. And if you're, I don't know, like if you're somebody like me, you have a full-time job, you have 3 kids, like good luck, like figuring something out in 2 weeks. So that's kind of how pregnancy dating works. Now, what are situations where like you might not know you're pregnant? So there's a very common condition called polycystic ovarian syndrome. And basically what that is it's where you have this trio of like elevated testosterone, this hyperinsulinemia in some patients, and ovulation, so you don't ovulate. And so what can happen for people with polycystic ovarian syndrome is you might go 6 months without a period, which you shouldn't do, and you should see your OB/GYN if that's the case. But you might go 6 weeks without a period and not know that you ovulated somewhere in there, conceived, and you might not find out you're pregnant until you go to the emergency department with abdominal pain or with like constipation or something, right? Or you might be at the doctor and they do a pregnancy test, because you should probably be doing a pregnancy test on a reproductive age woman. She's seeing you in your office. Your doctor does a pregnancy test and they're like, oh, you're positive. You put an ultrasound on and you have like a 16-week fetus.
Wow.
So, and it's not common.
And PCOS is increasingly common, actually, and especially in women of South Asian descent. I actually had Dr. Ron Sinha on the show. We were talking about this. It's very, very common. And so this idea that then you could be in an advanced state of pregnancy and not even know that you had ovulated, let alone conceived, let alone gotten pregnant, let alone advanced this. That's and again, that gets to the bioethics of now there's the bodily autonomy of the mom who is an independent actor. But then how do you think about when people will say, well, but this fetus also has some autonomy in theory. How do you think about that in your own conception of this in terms of the bioethics of mom versus fetus and so on?
I think that is a really, really challenging question. And for me as a provider, I think of my job as taking care of my patients' physical and emotional needs. And in my state, we don't do terminations past by. So when we say viability, that is sort of an infant's ability to be resuscitated outside of the uterus. And actually that gets into problems in people who have very highly desired pregnancies and they want everything done if there's a problem, like the 15-week, cervical insufficiency patient that we talked about. But I also think of my job as trying to be a passive, non-judgmental person, like actor in somebody's story. So it's not my job to work that out for my patients. It's my job to emotionally and medically support them. And there are situations where, the choice I would make for myself or the choice I would hope that my patient would make is very different. And that's okay, because I'm not living their life and their story. And I don't know what things they have acting on them and out in their outside life. And that's a little bit that gets into like our trauma-informed care model, right? Like people come to us with all kinds of stories and baggage, and it's not our job to sit down and figure out like, oh, well, were you raped? Because it's okay for you to have an abortion if you were raped. Oh, were you abused, or are you in a domestic violence situation? Like, that's not my job it's my job to screen for those things. But if they don't want to tell me that, that's okay. It's my job to say, whatever your story is your story. And I'm here to support you and give you the resources you need. So that's kind of how I approach things. And if there is a situation where I don't feel comfortable, I have excellent colleagues that I can refer to. And I think that for physicians who don't provide abortion care, it's okay. Like I have excellent, amazing, compassionate colleagues who don't provide abortion care, and that's okay. But they know that they can refer.
It's such a nuanced thing, and where it becomes less nuanced is when it's legislated. Yeah. That's when all that nuance goes away, because there's no longer a choice in that matter at all. Yeah. One quick thing, I think I hear something binging. Is that your computer or mine?
My computer. I tried to put on Do Not Disturb, but I'm like illiterate.
You know what? Do Not Disturb is a scam. I'm just telling you, people, everybody's watching. It's a total scam. You put it on and then people are still blowing up. Like they can still FaceTime you. Like I was doing a talk in Dallas the other day, and I had the thing on Do Not Disturb, and the phone's blowing up the whole time I'm doing the talk. Which is, the thing is, I'm conditioned. I don't know. When I was a resident, I had a whole thing. If I ever got paged, no matter what, and I told my house staff, the other house staff and everything, and when I was an attending, I still did this. Anytime the pager would go off, I would have to do the robot. It was compulsory. So if it would, the thing would go off, I would just stop whatever I was doing. It doesn't matter if it's in a code. It just doesn't matter. You got to do the robot. And that's my choice. We're talking about choice here. Yeah. That was my choice. So back to this actually very heavy stuff. So walk me through, and there's a couple things we should touch on. Well, one is, what would happen if again, we had a ban on elective pregnancy termination? How would that affect the practice in the women that you see? And we can go through some clinical scenarios. And the second thing is, let's do this first, because I can't believe people still think this is a thing. Reimplanting ectopic pregnancies.
So that is
what is an ectopic? Walk me through this.
Okay, so in case anyone was confused, you cannot grow a pregnancy in the fallopian tube. Cannot. It does not work. It will rupture, you will hemorrhage and die.
By the way, I just want to stop you right there. You did a thing just then that I want to point out. You said the fallopian tubes, and you did an impression of the fallopian tubes that was stunning. As a dancer, a fellow dancer, I compliment you. I do use the pole. You do not. Yes. So back to ectopic pregnancy, which is an implant. Tell us what this is.
So an ectopic pregnancy. So when I talk to patients about pregnancy, and usually they'll come in, they'll have some kind of vaginal bleeding, and I have to say, like, listen, this is either a normal pregnancy inside the uterus. When I say normal, I mean a pregnancy that's going to grow into a baby. It's an abnormal pregnancy inside the uterus, which is a pregnancy that for whatever reason is not going to grow into a baby and will eventually miscarry. And then there's an abnormal pregnancy outside of the uterus, which is a pregnancy that's not only not going to grow into a baby, but also can like kill you. And there's different kinds of ectopic pregnancy. And I think that that's another thing that gets into this like legislative difficulty. The most common ectopic pregnancy is one in the tube. And you can sometimes see an embryo or a fetus with a heartbeat in the tube. Usually it's more subtle than that. And sometimes we have to follow labs and do all this stuff to figure out that it's an ectopic pregnancy, but either which way, it's not a viable pregnancy. It's never going to be a baby. It's not possible. Hemorrhage and die. That's kind of
full stop. Full stop. Just to clarify, you cannot give birth to that as a viable entity.
You cannot, not in the tube. And so what eventually happens is that tube gets stretched, and like the fallopian tube, there's these blood vessels that run right underneath, and then that goes down and you have your uterine artery. This is my uterus. You have your uterine artery next to your uterus, and those little lovely blood vessels under there eventually like can tear. Pregnancies are very vascular. They kind of like to grow into whatever they're trying to attach to. And so we can get some bleeding or hemorrhage and death. As I mentioned, you can hemorrhage and die with an ectopic pregnancy. And so what happens if someone has an ectopic pregnancy? So option number one, if they meet certain criteria, you can actually give them medication called methotrexate. And then you have to follow their pregnancy hormone levels down to 0. And that is a non-surgical option to treat this non-viable pregnancy that will never be a baby that's in the tube. Some people don't meet criteria for methotrexate, or they don't want methotrexate. And then we do surgery. When you do surgery, there's a couple options. So we try and we offer something called salpingostomy. So that is where, if this is your tube, you make an incision on the tube. And you use some fluid to kind of try to dissect the pregnancy away from the tube. So you're detaching the pregnancy from the tissue it's latched onto, right? So you're essentially devascularizing that pregnancy. And then you're getting the pregnancy out of the tube. You're crossing your fingers and hope it doesn't bleed and it's not too shredded. Sometimes that's not possible. And then, or the patient doesn't want that. And then you can also do a salpingectomy, which is where you actually just take the whole tube with the ectopic pregnancy inside of it. So you're still devascularizing the pregnancy because you're cutting it off from the blood supplied to the tube. So let's just pretend that we would try to reimplant that non-viable pregnancy that's never going to be a baby. What you would conceivably have to do is then go vaginally, dilate the cervix, and then I guess you would take that pregnancy that you've devascularized and shove it up into the uterus. And by the way, it's probably not sterile, right? Mm-hmm. And then cross your fingers and hope that it attaches and then turns it like it's nothing.
Has it ever been done in the history of medical science?
Not that I'm aware of.
Yeah, me neither.
No.
Got it.
REI, so IVF, where you create an embryo and you have like the little clump of cells, and I'm not an REI, so REIs, please forgive me, I'm going to butcher this. But you have your embryo, and then they are very careful and they put it just so in the uterus, and they are very fastidious people. And that stage of that embryo is before it would have implanted in the uterus. Mm. So that's why that works, and the ectopic pregnancy thing does not.
Does not. And so when a woman is diagnosed with an ectopic pregnancy, they might have assumed they had a positive pregnancy test. They might have assumed they're legitimately pregnant. It might have been a wanted pregnancy. Mm-hmm. And then to find this out is probably, I imagine you handle it akin to a spontaneous miscarriage or an abortion with complications. Yeah, it must be some counseling and difficulty.
Yeah. And some people, everybody's different. And I have patients who will really grieve a miscarriage or an ectopic pregnancy as a loss of a whole person, right? They're grieving that as if they lost, a person that they know. And they are, right? They're grieving a whole future and a whole world that they're imagining with this baby. And now they're finding out that, and sometimes in very dramatic fashion with an ectopic, they're finding out that this is not going to happen anymore. And that counseling takes a lot of care, and we have support groups, and we now have people on social media who speak out about this more, but that's a real emotional loss for that person. And so even to have this like misinformation, I hate using that word, but even to have like this information out there from a politician who's not a doctor and didn't go to OBGYN residency, telling people this thing that gives them, some of these people, that's hope, right? Really sucks. And it makes my job harder,
Yeah, it's unconscionable. So that's where I get very passionate about this, because I actually, sitting in this kind of alt middle position and seeing everybody's sort of moral matrix around abortion is one thing. And I can see that. And I actually intuitively understand that. I think where it becomes problematic is where I see the medical science too. And I see the other emotional aspects of it, where people who have no business, legislating it or being in a position to legislate it are actually causing harm to others. Yeah. They're actually not allowing this, this moral reasoning to occur in between woman, doctor, family, their conscience, all of that. It's literally aborting that process of unfoldment of how we think about things. Because like you said, like the loss of a planned and desired pregnancy has a very different valence than, an unplanned, potentially dangerous, all the things we talked about, where now the choice is, this is actually the autonomy of the mother and the health and safety and mental well-being. Can you speak about peripartum depression and things like that in unwanted pregnancy? Is there data on that?
Yeah. So, first of all, so there are some good studies that in women or people who choose abortion, long-term, there's less mental health consequences. So ACOG has in one of their policy statements that, when you look at people, most of them afterwards will say, I feel like that was the right choice for me. Not everybody. And even if it's the right choice for them in retrospect, there's still a lot of emotional nuance with that. I can't tell you how many hands I've held, like while someone's going to sleep and they're it's not an easy decision for some people, right? So in terms of maternal mental health, so one of the risk factors for peripartum mood and anxiety disorders, and, we're talking like 15% of people after pregnancy suffer from some kind of peripartum mood and anxiety disorder. And one of the risk factors for that is an unplanned pregnancy. And so when you talk to patients, there's unplanned pregnancy. So again, 45%. And then there's undesired pregnancy, or someone who's not wanting to continue that pregnancy. And those are two separate things. So when people who have an unplanned, but they are choosing to continue the pregnancy, that's still a risk factor for peripartum mood and anxiety disorders. And then I imagine in these states where now that option is taken away, that's going to be even more of a risk factor. And so, and this area is really my love, but we don't have adequate resources for this in my state and my patient population. And I think we have like pretty good compared to some of my other colleagues I've talked to around the country. We don't have good resources. We don't have enough support groups. We don't have enough social workers. We don't have enough therapists. We don't have enough psychiatrists. Like me getting a patient into a psychiatrist is a nightmare. And so we don't have the resources set up to support these women, regardless of, what their situation is in getting to where they are having this baby, that, whether or not it was planned. We don't have the resources to set up to support them.
So maybe I'm projecting a little bit, but it seems like if you take away a person's agency, their ability to actually make, because you said you can have an unplanned pregnancy that you still choose to, have, and that itself is associated with some maybe increased peripartum, postpartum depression or anxiety. or mental health issues. But now, if somebody comes in and says, well, okay, you had an unplanned pregnancy, you have no choice but to deliver this baby to term and then make a decision what you want to do. Well, that changes the dynamic quite a bit. Now you've amped up the potential risk, I think, of those mental health issues. And then with zero support
Right.
from
Yeah.
any, yeah.
And we don't have data on that just yet, right? Because up until
Right.
recently, this was generally an option.
Right.
And, I might be missing, I haven't done like a thorough review on that, but
Right.
I imagine that this is something we're going to see it's already something that's increasing. And I imagine it's something we'll see increasing more. And you have to think like in the postpartum year, about 20% of maternal deaths are either suicide or overdose. So again,
it's a life-threatening issue.
right.
And again, it's that tension between, if your belief is that, the fetus is absolutely a life from conception until that tension versus the mom's life and her autonomy and her body and so on. And that's why it's a difficult thing, which you understand clearly. But again, that the legislative component just makes it that much more difficult.
Yeah. And then when we talk about life threatening, right? So how do you define that? So if somebody comes in and they say, I just found out I'm pregnant, I'm in mental health crisis, I don't think I can continue this pregnancy, I'm having suicidal ideation with a plan. Is that life threatening?
Right.
No. If somebody has a history of non-recovered cardiomyopathy, so non-recovered peripartum cardiomyopathy, so cardiovascular disease is one of the leading causes of maternal death in our country right now, right? So if someone has non-recovered cardiomyopathy, which means that they had a weakening of their heart muscle in and around the pregnancy or the postpartum period, and then that heart muscle didn't recover, their risk of death for that subsequent pregnancy is quite high. And so when you say when the legislation says life threatening, does it need to be she's septic and she's about to die? Does it need to be she's in total heart failure? Or does it need to be, is it 20% chance of death, 50% chance of death? How sure do we need to be she's going to die before we intervene? I don't think any of the laws say. So
this is the stuff that you don't, when they talk about this, it seems like everybody's factioned into a very extreme camp on this. Either, well, at least let me be clear, not everybody in online or in the media has factioned into either, abort them if you got them, or do not. It's a complete ban on it. And what you're missing is all this medical nuance that you're pointing out, which is why I think I really wanted to do this conversation with you, because that's what people don't understand. Like, what about that situation? And and this is the thing, we're talking about moral injury for physicians too. Like, if you make the decision and a court of law decides that you made the wrong decision based on the law, even though you were trying to do the right thing for that patient, you can go to jail.
Yeah.
So
so that's so back to our 14-weeker with the cervical incompetence. Let's say it's that same clinical picture. She has a dilated cervix, there's membranes in the vagina, we can't do a cerclage, and her white count is 25. But maybe she doesn't have a fever yet, maybe she doesn't have fundal tenderness, but you know where this is going. So her white count's 25. Is that life-threatening enough? And if you're the physician and you're in a state, like I think Georgia, their trigger laws, it gives like an embryo personhood. I think there's some of these laws, like you can be charged with murder as a physician. I'm a single income family. I have 3 children to support, And so now you're in this position where you know what the right thing to do is, and you can counsel the patient on the right thing, on like what the medically the safest thing to do is. And again, that might not be her choice, and that's fine. But that creates this horrible gut-wrenching feeling as a physician where you can't intervene to help this patient. And you are and even like the counseling and the emotional support you're able to provide to her is kind of messed up.
Yeah.
So
it's rather heartbreaking and terrifying at the same time. And again, let's just strip that away from whatever you think about abortion. Like, that's going to put physicians in a very difficult place, because you're talking about saving a mom's life and actually potentially going to jail because a legislator felt that, or a judge felt that you made the wrong medical decision. I mean, that's really not cool.
Yeah.
And that's what really, again, from the beginning, when I've been talking about it, it's been about, you can't legislate this stuff. It really has to be physicians and patients in cahoots making these decisions. But the more we know about the medical issues around it, I think the more people can make at least educated decisions when they go to the polls and vote for politicians who are making these claims.
Yeah.
Tell me a little about the medical pregnancy termination options, because that's another huge misunderstanding is, Mifepristone, RU486, these kind of things, morning after pill, what's the difference? Like, how do these things work?
So I think the first thing to understand is the morning after pill is not an abortion pill. So the morning after pill is going to prevent you from ovulating. It's not going to prevent an already fertilized pregnancy from implanting in the uterus. And that's kind of what, like with my patients, like I talk to them about the morning after pill, but I also tell them, like, listen, ideally, this is not your like primary form of birth control, because it doesn't really work that well as like a primary form of birth control, right? It's like the condom broke, we forgot to use the condom, like cat's out, sperm, right? Sperm is traveling up to where the egg's going to be. We know from earlier in our conversation, sperm can live a long time. It's just preventing the ovary from releasing that egg and getting fertilized, right? So that's plan B. So, legislating plan B because you think it's an abortion pill, like, is just not really based in logic or fact.
That's just straight up nuts. Yeah. Yeah. And let me reiterate. So if you've already ovulated and you have sex and the sperm are going up there, plan B isn't going to do anything. It's not going to abort that, what's it called embryo. At that point where embryo.
Yeah. The blastocyst. Yeah. It's like forms, and then it's a blastocyst and gets fertilized and it travels down the tube and goes, if that's happened already, like, it's not.
When's my boy a zygote? Because I forget. I like that term, zygote.
I have to look it up. I'll have to know that from my oral reports. I can't remember.
It matters not a lick clinically, but I just love the word zygote. It just sounds like a metal band from the 80s,
I know. But, well, Z-Dog Zygote, it's like some great alliteration too. So.
Oh yeah, that's right. So
back to medical termination of pregnancy. Yes, so that's plan B, right? Plan B is there's some sperm up in there. I really don't want to release an egg and get pregnant. Then there's Mifepristone. So this is another situation where the legislation gets really challenging, because Mifepristone, initially we were using this as for part of a medication termination, which we'll kind of talk about. Turns out, and it's progesterone antagonist, which means it like blocks the progesterone receptors. Turns out it works really well for other things like medical management of a miscarriage. So if I have somebody who comes to me and they're really excited about their pregnancy and they're like, have their partner there and they're FaceTime with mom and they're so happy. And then I put the ultrasound in and there's a fetus and no heartbeat, right? So that's a missed abortion or a miscarriage. It's still in the uterus. One of the things I will offer to them, so expectant management, medication management, is Mifepristone followed by misoprostol, the same dosing and regimen that we would use for a medication termination, but now we're using it to help a person pass their non-viable pregnancy so that they don't have to have a procedure. And it turns out, when you look at the studies, using Mifepristone in that circumstance decreases the chance that she's going to have to go to the OR for a procedure or into the office for like an MVA and a very uncomfortable awake procedure. So when you are now creating legislation around this medication that's used for other things besides termination of pregnancy, you're also making it a lot harder for me to treat my patient who just found out that pregnancy that she's already in her head, like designing her nursery, and she's like texting her mom and her sister, and she's so excited. That person's also suffering because of that. For medication termination, it's a really great option because you don't have to go to the OR or have a, mildly to moderately to very, depending on the situation, uncomfortable procedure awake. And you're not needing now, if you go to the OR, you need a COVID test, you have risk of anesthesia, all of this stuff. So it's basically, you can use Mifepristone and Mifepristol for pregnancy termination from basically when we find out you're pregnant up until 10 weeks of pregnancy.
10 weeks.
Yeah, 10 weeks. And that's based off of, the ACOG guidelines. I know that there's some organizations that I think will say you can do it up to 11 weeks. In my practice, I go up to 10 weeks with medication termination. Then after that, it's procedure. But what that allows is it's a pill in the office. It's 4 pills, either in the cheek or in the vagina, 24 to 48 hours later, 12 to 48 hours later, depending on how you take it. And then essentially it feels like a miscarriage. It feels very natural. It's 95 to 98% effective. It's very safe. And so that would be a medication termination. That medication turns out now for Mifepristone, we're also using it for people who've had a fetal demise. So for people who have now a viable pregnancy where they're into their 3rd trimester, and they find out that the baby has died inside. Now there's some literature supporting the use of Mifepristone to help kind of like speed up that process of helping her to deliver that pregnancy.
I see. So you don't have to do a surgical procedure. You can have a birth of the stillborn fetus. Is that the technical term? Is it stillborn at that point, or?
Yeah, stillborn. We call it an intrauterine fetal demise, but
got it.
And then depending on the gestational age, you can either do a surgical procedure, or sometimes it's actually much safer to induce labor depending on gestation. But
and it's such it's such an emotional and traumatic thing. It can be because you're, this was a desired pregnancy and you're delivering, stillborn fetus, but so Mifepristone can potentially now is being looked at even to help with that. Yeah.
Mm-hmm. Yeah. So it's a really great medication that improves patient outcomes outside of pregnancy termination.
So we're talking about legislating it out of existence is probably not the most scientifically valid approach a legislature could use.
No, not evidence-based.
I'm going to get my pitch in here, kind of like mandating masks for a 2-year-old. But what do I know? Nothing. Sorry, I had to get my...
Yeah, it's so funny because everyone's like, oh no, COVID, wow, don't tell me how to do my job. And I'm like, dude, they tell me how to do my job like forever.
It's really, again, it gets to autonomy, right? It gets to autonomy. Like I always, when I do my talks now, I talk about when you want to do, if you're in a service industry, which I hate to say this, but we are as physicians, we're serving others. There are 3 things you need to do your job well, to feel capable to do your job and to have good outcomes and to have all of that. One is tools, which is technology and gadgets. The second is teams. So the kind of support, the training, and the teams that support you. And the third is trust, which is another way of saying autonomy, saying latitude to do what we do. And what this legislation in general, these legislative approaches to women's health, they take away the trust component. They take away tools, and that hobbles people's ability to do medicine. Now, one thing I think we didn't mention was, what if you took a drug, a medication that actually, and then you found out you were pregnant and you were already on this medication, and that medication puts the child at the fetus at extreme risk for deformities, terrible outcomes, et cetera. And, like what's a good one? Accutane, isotretinoin.
Really good one.
Yeah. So it's an acne medication, and young women may take that, and they're supposed to take birth control and all that. But what's your experience with this?
Yeah. So I fortunately have never had a patient become pregnant while taking Accutane. I take care of a lot of patients who are on Accutane. And I used to be a medical assistant for a dermatologist. So I used to do the other side of this.
That's why your skin's so good. Yeah.
Well, it's also like the thing on Zoom that makes you look better.
I need that thing. I had to
Yeah.
have Logan design a custom beauty filter for me that makes me look 30 years older than my stated age. But
I know.
anyways,
That's what I need. I need like some gray hair so people aren't like, are you a medical student? I'm like, no.
people love the gray. People in medicine, it's the only field where looking older is an advantage.
Mm-hmm.
Yeah.
But what we're saying, Accutane. Okay, so Accutane. If you're taking Accutane, you basically need to have be using two forms of birth control. So that can be like a pill and condom. I mean, usually it's like a pill and condom or IUD condoms, whatever. And you have to like sign a thing. And I was a medical assistant like a long time ago, filling out these forms with patients. So if it's changed, I'm sorry, like, please correct me. But anyway, you have to show that you're using like some form of birth control.
Does pull and pray count?
No. Does not. They get out before they can get out before the full orgasm. It doesn't work. They're really tiny and fast and live a long time.
So no to ixnay on the pull and pray. All right,
Ixnay
good to know.
on the pull and pray. That is
it may have been my own personal sole form of birth control in my entire life, but again, it may have been. This is all theoretical.
You have two beautiful children, right?
I do have two children.
I mean, what I tell patients, if they tell me that that's their option, my question to them is, how much of a disaster would it be if you became pregnant?
Yeah.
And if the answer is it would be a total disaster, I say, maybe we should talk about some other options.
There you go.
If they say, no, I mean, it would be fine. I don't, not really right now. It's not a great time. If I became pregnant, it's cool. Okay, great. Pull and pray. Great. Fine. You do you. But if you're on a medication like Accutane that causes birth defects, not a great option.
Not a good idea.
Even birth control pills. Like I tell my patients, I'm like, listen, I can't take a pill every day. Like I would have 8 kids if I was on birth control pills. So some people, that's not a good choice because they can't remember to take a pill every day.
Well, what are some other medications that you get concerned with in pregnancy where you've had to counsel women who've been on them and now they've gotten pregnant? And again, if you take away the option for pregnancy termination, you're potentially telling a woman that she's got to deliver a baby that could have serious harm upon it from these medications.
Yeah. So I think that that's a really good like space to get into also like maternal anxiety, right? So I have patients who were taking, they had like 2 sips of alcohol from when they ovulated until when they found out they're pregnant and they're losing their minds, right? Yeah. Which that baby's going to be fine. It's going to be fine. It's okay. And then I have then there's like the theoretical patient who's on Accutane or somebody who has poorly controlled diabetes. So a very common thing that we see, right? Hemoglobin A1C of 10 or above, you have a 10% risk of birth defects.
That's huge. And huge. And there's so many diabetics poorly controlled out there. Right. And again, it becomes an equity issue because often in socioeconomic groups, social determinants of health that lead to that. Poor care, poor diet, poor nutrition, poor access to exercise and nutrition.
They can't afford their insulin.
Right.
So like this week, I've had patients who have to tell me it's either insulin or healthy food for my kids. Right. Wow. So they can't afford their insulin. People who are diabetic also have, increased risk of renal disease, increased risk of like vascular disease, cardiac problems, eye problems, all of those things get worse in pregnancy. But it's not a medication, but that's a really good example of something where there's something going on with your body that's going to affect the baby. So if you have an unplanned pregnancy, all of a sudden you're in the situation where something that you did is affecting the baby and it's not your fault, right? But that's how a lot of women are going to feel. And so taking away that option for them is not only difficult from like a health perspective, right? But in an equity perspective, but also from an emotional perspective. And
another example might be you are diagnosed with cancer and and then become pregnant or vice versa. And now you have to choose between, do I get chemotherapy and treatment that would injure this baby, or do I have a pregnancy termination and save my own life potentially? So again, it becomes that difficult situation.
Yeah. And, even, I mean, you'd be surprised at how many chemotherapeutic drugs you can get when you're pregnant, and there's
Mm,
protocols for that.
mm,
But there's certain drugs that you can't get, and you certainly can't get pelvic radiation therapy, right? But you're having to choose. There's some cancers where maybe the standard of care and the thing that's going to make your outcome the best is to get pelvic radiation therapy, and delaying that treatment, because the other time, like, when do people who don't have access to healthcare access a doctor? When they become pregnant.
mm.
And so we pick up cervical cancers, we pick up breast cancers, we pick up undiagnosed diabetes, we pick up untreated depression, anxiety, mental health concerns. Like, we pick all these things up sometimes with the pregnancy.
Mm.
But back to cancer. So you might be able to get treated, but you might not be able to get the thing that's going to optimize your health the most. So is it going to put your life at risk during the pregnancy? Maybe not. Is it going to shorten your life, and maybe your 5-year survival likelihood of 5-year survival number, is that going to decrease? Yeah, maybe. And then, the other component of that is you need like a highly specialized team to take care of you if you're a pregnant person with cancer. So again, at my institution, I'm very lucky. We have maternal fetal medicine, we have awesome oncologists, we have awesome like radiation oncologists, we have all of that at our institution. And if we have a patient who is pregnant with cancer, we can get her in and get her going really fast. But if you're in the middle of nowhere in Oklahoma, you're delaying care for that cancer. And it might be more efficacious for you to have a pregnancy, like a medication termination, and then proceed with your chemotherapy or your radiation therapy or whatever. And again, that's taking a huge component of bodily autonomy away from a person. I think that if you have cancer, you should be able to choose to get the standard of care treatment for that cancer if you want it.
Yeah. Yeah. Yeah, and these are key points that I think, again, they're glossed over when the media talks about this issue. It's just, again, polarized into black and white, whereas there's this nuance that you guys on the front lines caring for these women actually understand better than anybody. So a question then maybe that might bring us full circle here is how would we, in an ideal world where we want to prevent unwanted pregnancies, pregnancy termination, et cetera, how would we do that?
Yeah. So, I mean, where does that start, right? It starts with education. So right now we have terrible sex ed in our schools. I know this because I get to talk to some middle schoolers and high schoolers periodically, and the things they believe about sex and getting pregnant are insane. And the things they believe about birth control are insane. So,
Like what? Like, is it either abstinence or pull and pray? Because that was my teaching.
yeah,
I grew
or
up
I
in the
know
Reagan era.
I had a lot of teenagers be like, oh, well, I'm not going to go on birth control pills until I am in a relationship where I don't want to use condoms anymore. And I'm like, no, 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 please don't do that. Like, use the birth control pills. The condoms are like best, like 85-ish% effective. They're not that effective. Use the condoms and the birth control pills. Also prevention of sexually transmitted infections, right? Like, also condoms great for that. Also, we talk to people about PrEP. Like, there's a lot of education that's not happening because of legislation. And I understand people are like, oh, you shouldn't have sex before marriage, blah, blah, blah. I grew up part of my life in Mississippi. I can tell you, even like very religious people, some of them still have sex before they're married. And you know what? It doesn't mean that you're going to have sex right away. Maybe you save that information until you're married if you feel strongly about that, and you don't want to get pregnant right away because you're in medical school or you're trying to buy a house or whatever. But education first, right? And then the next one is easy, affordable, and accessible, effective birth control. Easier said than done. And places like Planned Parenthood are awesome for that. Like, when I was in, where was I, college, in between college and when I was out in the world as a young adult, I had no health insurance because this was pre-Obamacare. Where do you get birth control? You go to Planned Parenthood. Where do you get your pap smear? You go to Planned Parenthood. So that, right? But we're wanting to defund Planned Parenthood, and we demonize them because they, are and provide abortion care, but they also provide like education and birth control and primary care and social services, and they screen for domestic violence and sexual assault and all these other things, right? So that, and then good health care, right? So if you want somebody's a bad diabetic, but maybe they really do want to have a healthy pregnancy, you make sure their diabetes is well controlled before they're pregnant, or their hypertension is well controlled before they're pregnant, because that obese, diabetic, hypertensive person, when they become pregnant, their risk of worsening of their diabetes, worsening of their probably kidney disease, worsening of their retinopathy, progression to preeclampsia with severe features, risk of preterm birth, all of those things are much higher when those medical problems aren't controlled. And then if somebody does become pregnant and they choose to continue that pregnancy, but they don't have good social support, you need good social support for those people after, which we don't, right now, we don't have any of that. We have zero. So we have none.
It's really, okay. So again, America does everything its own way, but it's kind of crazy. We have none of that. None of that at all. Our primary care is crap. We fund specialty care. The social determinants of health drive everything, but we have no social support. We do not have any kind of equitable access to healthcare at all. But now we're going to say, yeah, but you can't have an elective pregnancy termination in consultation with a doctor. Even if you have all these other problems, you're going to go through this mill. And look, if you really believe that this is that abortion is a problem morally, then we should morally and ethically do these other things to make it either unnecessary or not. But as you see, the word unnecessary doesn't even make sense, because there are those medical necessities that we've talked about where it's always going to have to be in the tool belt of physicians, because you're talking about a mother's life who's at stake, right? So,
yeah. And I mean, define necessary, right? So I think, I forget which state it was. I've honestly lost track of all the trigger laws that are going into effect. I had them down like a week ago, but now there's more. But I know there's one state that just created a trigger law that does allow for rape and incest, but only a third of women report rape. And the majority of rapes are perpetrated by somebody you know. So do you have to report the rape so that you can have the termination from the pregnancy? And if you find out you're pregnant after the rape, it's going to be at least 2+ weeks. And then you're not going to be able to go report the rape and do the rape kit. And then also we blame women when they do report. So how's that going to work?
And then the doctor gets it wrong and goes on trial, right?
Yeah.
And so that's where this is all. I mean, and this is where your practice of yoga comes in handy, because you're going to need some serious mindfulness the next few months and years. Are you still practicing? Do you still teach?
I still practice. The last time I taught a yoga class, I taught when I was a resident to some of my fellow residents, but actually with some of my trauma-informed care work, I do more like mini mindfulness practice with the residents and with my patients. So yeah, I use a lot of mindfulness with my patients, actually.
So you said trauma-informed care, and this is one of your passions. Can you give us the one-liner on that?
Okay. So the one-liner is,
it can be more than one line.
So trauma-informed care is, number one, recognizing that trauma is common. And most people are going to underreport, right? So trauma is common. A history of trauma. And when I say trauma, I don't just mean like you've been raped, right? I mean that you're a person of color in America, or you're somebody who's an LGBTQ person in America, or your parents neglected you as a child. Like trauma, many shapes and forms, right? So trauma is common. Trauma is going to affect your health, and it's also going to affect the way that you approach healthcare. It's going to affect your ability to have trusting relationships, especially with the healthcare system. It's recognizing that the healthcare system can iatrogenically re-trigger you or re-traumatize you. And it's also recognizing that you can form healing and trusting relationships within the healthcare system. So that's like in a nutshell. I mean, we could talk several
Oh,
hours.
so that's going to be another show because I'm really interested in that because personally I suffered trauma. I did not get a car when I was 16. And to this day, I consider that an adverse childhood experience. And
We're
it's the reason I
neglected.
have gout.
It's 100% the reason you have the kidney disease.
I don't have gout, but I've always wanted it. I don't know why. It just feels like a disease of affluence that I've earned, you know?
Yeah.
Um, no, but in all joking aside, the trauma-informed care thing, I think we really should do a whole nother show on that because especially in women's health, that is a crucial discussion that many of my audience have asked about.
Yeah.
Some of them are involved in practices around that, but many of them are actually, victims of trauma, et cetera. And so it'd be important to talk about. But I got to say this, Alex, like, is there anything else you want to say about this issue?
The trauma-informed care issue or the abortion?
Sorry, the abortion issue, because I think we did a thing like,
yeah. So I think like the big thing to recognize here is that abortion care is something, and this is coming from ACOG, right? So ACOG is like my boss organization that
the
tells me
American College of Obstetrics and Gynecology.
Mm-hmm. So they're a nonpartisan organization. Their stance is that abortion care is a part of comprehensive reproductive health care. And that decision should be made by the patient and their provider, their physician, and taking all of their health needs, wants, and clinical situation into account, and then coming to a decision. I think the other thing that's really important is that you don't have to be a physician who provides abortion to be affected by these laws and issues. You can be a physician who manages miscarriage, who manages adverse pregnancy outcomes. You can be an IVF physician, a GYN oncologist, an oncologist, or
a pediatrician.
Yeah. So this is something that it doesn't just affect people who provide abortion, and most people who provide abortion do other things, right? It affects a lot more physician-patient relationships than we really give it credit for. And ultimately, what's going to happen with this is it's going to take away our ability to provide the standard of care and evidence-based medicine. And that is not safe for patients. That is not safe for physicians from a mental health perspective, from a medical legal perspective. And it's also not good for our society, right? So the people who are going to be most affected by this are people who don't have access to healthcare, people who are poor, people of color, and are already horrible, maternal outcomes that we have in this country are going to get worse. So that gap where we have a woman of color, so a Black woman or a woman who's a native, I'm going to use the wrong terminology, but American natives and Alaskan natives has a 3 times more likelihood to die from pregnancy than a white person. Over the age of 30, they have a 5 times more likelihood of dying from pregnancy than a white woman. That's going to get worse. And I think these states with these laws are also going to suffer a loss of OBGYNs, because I know for myself, I couldn't practice in one of those states. So I don't know. I don't know what's going to happen. But I'm hoping that we can at least see that there's nuance here. And while I totally feel for people who truly believe that life begins at conception, and I imagine how heartbreaking it must be to feel that and feel that that's truly a death and a loss with every termination of pregnancy. I imagine that must be just gut-wrenching. I hope that we can at least see that this is such a nuanced and complicated issue that our politicians are just not really qualified to make rules around.
And all those things can be true at once, and they are. And that's why I'm so grateful that if people say, "Oh man, do you read your comments?" And it's like, yeah, I do, for this reason, that every now and again, there'll be one that is so thoughtful and informative and professional that it makes me think, you know what, we should talk. And I'm so glad we got to talk, because I think people will learn a lot from this. And they can disagree with abortion, but the medical stuff, I think, is very important to spell out, because again, it's the nuance that it's very hard for the mainstream media to actually pick up on properly and convey, because there isn't that much time.
Yeah.
So Alex, so we're going to come back, and I want to come back and talk the next show about trauma-informed care. I want to talk about maternal mortality and why it's so abysmal in the US, how we can make it better. And I want to talk about the lady parts, which frankly, I still don't understand. Like, this is a fallopian tube. I used to think the fallopian tuba was an instrument and the epididyphone was also an instrument. So I'm an equal opportunity, ignorant person when it comes to reproductive organs.
I'm just disappointed we didn't say vagina more in this. I really
You know what? I like to say vag because I think it implies a level of professionalism that others just lack, quite frankly.
Oh, yeah.
Well, guys, I hope you enjoyed this vagina. There, I said it. Does that make it better?
So much better.
Probably not in that context, but guys and gals and non-binary pals, I really want to thank Alex West for being on the show and talking to us. If you like what we're doing to educate, please share the video. Leave a comment about your own experience, your own thoughts about this. Be civil about it. Be persuasive. If you want to persuade us of a point, use your moral reasoning and make a persuasive point. Don't start throwing feces. And if you really like what we do, support our show like Alex does. Actually, that's how we met. She's a supporter in our supporter tribe. It's like $5 a month. You can do it on locals.com or Facebook or YouTube, and it helps fund all of this. And we have these really in-depth discussions in a really civil way. Like, Alex may have disagreed with the way that Doc Vader went at abortion, and she very politely and professionally wrote back, and now we have a conversation. That's just awesome.
I also really love Doc Vader's milk formula crisis video.
Oh, did you? So you'll appreciate this, because I sometimes go hard on the lactation consultants for a little bit of shaminess, because I think my wife suffered through that and was quite emotional about it. A lactation consultant reached out who is also in the supporter tribe and is going to come on the show by Zoom to talk about the formula industrial complex. And so we'll get a good angle on that, and it'll be a good conversation.
Nice.
And hopefully I'll learn something. But Doc Vader does not, they tried to force Luke and Leia. Again, Padme's no longer alive. They tried to get her Force Ghost to lactate. I don't know about you, but it's very difficult to suckle on a hologram. I've tried it. Please forgive me, Obi-Wan. Anyways, guys, thank you, Alex, for being a good sport. And we are out. Peace.